I'll be presenting on Nanophthalmos. By definition, it says it's a short axial length less than 20.5 or 2 standard deviation below mean with a small corneal diameter and a shallow and crowded anterior chamber. There is thickened sclera and there is increased tendency for uveal effusions. This has to be differentiated from relative anterior microphthalmos and axial hypermetropia, wherein there is no thickened sclera. Preoperatively, axial length measurement and biometry, accurate biometry is crucial because a small error in axial length measurement can result in a wider variation of IOL power. Selection of suitable IOL calculation formula is very important. Literature review says Hofecu or Holiday 2 or Haigis is wonderful for these eyes. High IOL power usually requires customization or the option of piggyback lens. We need to treat glaucoma with topical medications or laser or trabeculectomy depending upon the stage of the disease. One complication of this eye per se is uveal effusion, which has to be treated either with or along before cataract surgery with the prophylactic sclerotomy. The technique shown here is a single quadrant sclerotomy, wherein we make an incision, a partial thickness scleral flap from 10 to 12 millimeters away from the limbus. A 4 into 4 millimeter of flap is being lifted up, followed by a deep scleral block excision of 2 into 2 millimeter. When the choroid is exposed, as shown here, the edges are cauterized so that doesn't close spontaneously, followed by a closure of the flaps. Surgically, when we perform phacoemulsification, the anesthesia would be a topical and intracameral anesthesia or a peribulbar block would be fine. Preoperatively, we need to give intravenous mannitol to reduce vitreous positive pressure. A proper wound construction is important. Slight anterior entry is preferred because to prevent the iris prolapse through the incision. Usually, these patients do have a non-dilating pupil, so we might have to use an iris hook or pupillary expanders. A soft shell technique would be good to preserve the space and to preserve the endothelium. We need to adjust the bottle height to achieve a stable chamber. Limited pars plana vitrectomy may be required to reduce a severe positive pressure, as in this case. Like we have a patient here, axial length of about 16 millimeters with a severe positive pressure. So we decided to proceed with the dry pars plana vitrectomy before we started our phacoemulsification. Placement of iris hooks to dilate the pupil, followed by rhexis and a gentle phacoemulsification, followed by bimanual aspiration. We have to use a light probe to visualize the intraocular status because of the poor corneal visibility. This is a customized IOL of about 46 diopters. So we had to extend the section to place it and followed by the closure of scleral wound. If in course of time there is chamber fluctuation, we might have to anticipate uveal effusion and treat it. Implantation of IOL, customization, if it is available, then that is the way. Like it can be placed in the back. But if we do not have customized IOL and we are planning a piggyback IOL, maybe the maximum power has to go into the bag and the residual can be placed in the ciliary sulcus. If you are dealing with a patient who has got a refractive surprise or a residual power, then we can implant a piggyback IOL as a secondary procedure also. In that case, we have to depend upon the refractive error of the patient. The spherical equivalent multiplied with 1.5 gives the adequate IOL power to be implanted. So the take-home message from my side would be a proper preoperative assessment of IOL power and axial length, meticulous surgical steps as we discussed, pars plana vitrectomy and sclerostomy to prevent uveal effusion, customized IOL and piggyback IOL has to be, we have to use these things, and we need to recognize and treat complication as and when required. Thank you.
Thank you so much, Vidya. You can stop sharing. Gaurav, would you like to comment on this? Any experience of using these high-powered lenses?
Yes, in fact, she's covered up all the points very nicely. Only thing is these lenses have to be customized because even if you're thinking of a piggyback lens, sometimes it's difficult to actually have enough space. You have to see what is the AC depth and the lens thickness obviously is much more, but that's obviously gone. So the customized lenses, have this disadvantage that they will not go in from any injector because they're usually so thick that it'll be very difficult to get them in through any kind of an injector. And therefore she had to use the the incision, and it had to be finely sutured. But that's a mixed bag because such a small eye which is high risk, making a corneoscleral wound and then having to put in the lens. So there is no perfect way to tackle these situations. But what was interesting was also that how you were able to show that making the small pocket and then suturing that. I was wondering that when would you decide to do that? I mean, in which cases would you choose to do that preoperatively if you had to do that? You mentioned that there's some eyes where you would actually do it preoperatively if you're suspecting this situation. The
I
UV
also
diffusion.
want to add things which any of you in the panel could answer. I came across quite a few articles which say that doing a prophylactic sclerostomy or not doing it is similar, does not make a big difference. And again, the other question is, in an anophthalmic eye, doing a pars plana vitrectomy itself is going to be a challenge because again, the position of the pars plana is not going to be where it should
Absolutely.
be. So these are 2 points which have to be kept in mind when you're doing a surgery in a small eye, and for a routine cataract surgeon, it cannot be taken lightly.
Well, if I can add something, today with the closed eye surgery that we do, probably this post-sclerotomies are out of vogue for most of us. But what I want to really mention here is that, well, maybe pre-op mannitol would really shrink the vitreous body and probably give you some more space. Because part of that, if you don't have, I think pars plana vitrectomy before is certainly can be done. With regards to lens, well, yes, we have, India is that way lucky because we can get these customized lenses. If your IOL power is accurate, you will get a lens, and like how it was mentioned, that the problem is with the injector. But then if you are keen on putting a foldable, and if you don't have it, sometimes they can provide you with a bigger injector, but mostly they don't. So that's the time when, if you are used to your older days, when you used holder method. Now these lenses can be implanted with a holder through a 3.5 or 3.75 incision. But I know of some of our surgeons who have got excellent results with up to 56, 57 diopters lens custom made for them by IOCare. And what they did was, what he said, I got a lens made, I made an incision very comfortably, and without business of folding it, I straightway put it in. And the beauty of refractive accuracy that they get is superb. But since we are used to putting the piggyback concept, my practice is I would use the maximum power that's available on the shelf. That will be around 40 diopters. And then I will not do piggyback at the one sitting. I will wait for the refraction to stabilize and then put one of those patch lenses or a sulcoplex lens of a required diopter, and that will require another surgery. But the second surgery is a very quick and short surgery, but the level of satisfaction the patient gets is super. Thank you.
I can't agree more with you, Suhas. I mean, I think we are fortunate in the sense custom-made lenses of even plus 60 diopters can be made. One thing is the amount of spherical aberration that these lenses have is very extreme. And calculation of the IOL power in these cases, whatever formula you use is never accurate. So debulking the majority of the power with a plus 40 diopter, good lens which is available, then subsequently using the simple formula into 1.5 for the residual hyperopia truly works. And even in these small eyes where there's a 4 millimeter anterior posterior diameter of the normal lens, you have enough space to put in 2 intraocular lenses. I think that gives you extreme accuracy. And as was pointed out, as far as this posterior sclerostomy is concerned, the concept was if the thickness of the sclerocorneal complex is more than 1.7 millimeters, you go ahead and use this posterior sclerotomy. I think that's a hangover from our ECC days when we used to have a large incision. Now with a controlled incision, maybe the requirement for it is much less.